Good afternoon, all. We're going to go ahead and continue in our spinal cord injury lecture series. Maybe somebody give me a thumbs up to make sure that you're hearing. Thank you. I appreciate it. Hopefully the residents will come on board. I'm not seeing any of them at the moment. But we're going to be talking about cardiovascular consequences of spinal cord injury today. And so as we go through this, we'll review the neurogenic consequences of spinal cord injury on the entire cardiovascular system. We're going to talk through the risks for VTE and PE following spinal cord injury, including prophylaxis and management. And then we'll talk through risk factors for coronary artery and peripheral arterial disease following spinal cord injury. So, as a reminder, we are looking at aspects of the central nervous system as it interacts with the autonomic nervous system and somatic nervous system. Most everybody is familiar with the different levels of spinal cord injury that we tie to specific myotones that are listed here on the screen. We recognize that this also includes the dermatomes, and so the sensory fibers. But we also have to keep in mind, particularly with regard to the cardiovascular system, the influence of the autonomic nervous system. So the autonomic nervous system, remember, is comprised of both parasympathetic nervous system and the sympathetic nervous system. Of the two, the parasympathetic nervous system arises primarily from the cranial and sacral portions of the central nervous system, whereas the sympathetic nervous system arises from the thoracolumbar regions of the cord. And we're going to talk through those a little bit more. Keep in mind that the cardiac plexus is innervated from T2 to T4, and the celiac ganglion provides sensory information from T5 to T11 with regard to the sympathetic nervous system. So we remember from our previous discussion in autonomic dysfunction that the sympathetic nervous system has both preganglionic and postganglionic fibers. The preganglionic fibers use as their neurotransmitter acetylcholine, whereas the postganglionic fibers release epinephrine or norepinephrine. And the primary role of the sympathetic nervous system is to provide the body the resources it needs to fight or flee. That is ergotropic responses. The parasympathetic nervous system, on the other hand, arising from the craniosacral axis, has acetylcholine as a neurotransmitter from both its preganglionic and its postganglionic fibers. And we remember that the parasympathetic nervous system is primarily implemented to provide energy conservation, provide a replenishment of resources used during a fight or flight response from the sympathetic nervous system. So once we've survived the crisis, hopefully, if we didn't, then the parasympathetic nervous system is going to be off anyway. But if we survive the crisis, then the sympathetic nervous system will back off, and the parasympathetic nervous system will become dominant during this period of rest and restoration. So we're going to see, with regard to cardiovascular influences, we're going to see a reduction in heart rate, stroke volume, and vascular tone. Blood pressure should drop. And during this time, the body is really going to invest energy to the GI tract to increase peristalsis and digestion to help us replenish those substrates that were utilized during the crisis situation. So we've talked through autonomic dysreflexia, but just as a reminder, this is a massive sympathetic outflow in response to a noxious stimuli below the level of injury in spinal cord injury lesions above T6 primarily. Now note that I didn't say complete lesions. So incomplete lesions will also yield this autonomic dysfunction, autonomic dysreflexia. And we know that also, while T6 is the primary level that we talk about, occasionally folks will have the greater splanchnic nerve, the nerve to the adrenal medulla coming off at T7 or T8. And so the T6 demarcation is because in most cases, more than 90% of the time, for any individual, the greater splanchnic nerve comes off at T7 and T8. And if you don't have autonomic control over T7 and T8, that is the greater splanchnic nerve, then in response to noxious stimuli below the level of the injury, you are going to have this sympathetic outflow causing vasoconstriction of the splanchnic vascular bed. And that is going to cause a hypertensive crisis, and potentially the individual could, what do they do in the autonomic crisis? Anyone? Stroke out and die, that would be suboptimal. Wow, I think everybody's asleep today. Or perhaps I'm not speaking clearly. Let's see, in the chat. Oh, suboptimal, thank you, Liz, I appreciate that. At least somebody's watching. So we keep in mind these differences in the cardiovascular system that occur because of the spinal cord injury. Now, the likely culprit for autonomic dysreflexia is what? Gee, you should really know this. Anyone? Wow. Is anybody hearing anybody besides me?
I can't hear anybody else but you.
All right, so this is the GU tract, the genitourinary tract. That's the most likely cause of autonomic dysreflexia. When the person distends their bladder, basically signals ascend the cord but are blocked at the level of the spinal cord injury. You get this massive sympathetic outflow, this reflex response that causes splanchnic vasoconstriction and hypertension. Increased pressure is sensed by baroreceptors that send information to the medulla, which sends information back to the heart and causes a bradycardia. But below the level of the injury, the person remains vasoconstricted. Above the level of the injury, we see flushing, sweating, and a pounding headache that we refer to as autonomic dysreflexia. Is this ringing any bells? I'm hoping somebody will come off mute and just say, yes, I remember this. Anyone, just anyone. I see a thumbs up. Thank you, Dr. Farkas.
Yes, I remember.
Yes, I remember this.
Thank you. Oh, somebody's still there. So the autonomic influence on the cardiovascular system, remember, is going to be blunted with regard to the sympathetic nervous system in injuries of the high thoracic and cervical cord. And subsequently, we're going to see these types of cardiovascular responses. Circulatory hypokinesis. What is this? This means that the circulatory system isn't working as well as it should. And why is that? Part of it has to do with the diminished afterload associated with sympathetic blunting. So remember that sympathetic blunting is going to allow relative dilation of the arterioles and that part of the vascular tree, so blood pressure is going to be low. So the heart is going to have to push less against that portion of the cardiovascular system. On the venous side, you have a couple of things. Again, diminished sympathetic influence is going to result in Veno Dilation. And remember that also a person who has paralysis of the lower extremities is not going to be able to activate those muscle pumps. The muscle pumps is usually what you and I use to help return venous blood back to the heart. And remember, the venous system has these valves that close in between the muscle pumps. So we are caught in a situation where we have a diminished afterload and a diminished preload. Remember that your usual volume of blood in the inferior vena cava is about 500 cc's, half a liter. But after a spinal cord injury, when you have sympathetic blunting, you're going to be holding about 2 liters of your total vascular volume in the inferior vena cava, okay? So what's that going to do to the left ventricular end diastolic volume, or the preload? So somebody help me. I'm seeing Dr. Farkas, but no one else. no one else remembers. Could that possibly be true? Anyone? Anyone? Left ventricular diastolic volume will decrease in response to a reduced sympathetic tone and a reduced venous pump. And so subsequently, your heart, which is a muscle, is pushing against a lower resistance. It's receiving less blood to stretch it, so you don't have the Frank Starling mechanism to cause contractility. And ultimately, the myocardium atrophies. And so when a muscle atrophies, what is its ability to perform work? Yes, it decreases. Thank you, Denora. I appreciate that. Wow, my residents have fallen asleep. So you have a decreased preload and a decreased contractility, and essentially you have a diminished cardiac reserve. The heart, because it's atrophied now, just can't push as hard as it could before the spinal cord injury and the sympathetic blunting. In addition, you've got diminished sympathetic influence on the sinoatrial node. And so a relative parasympathetic dominance to the SA node will do what to the heart rate? Wow. So your heart rate is going to decrease under parasympathetic influence of the vagal nerve. Remember, the vagus nerve and the sympathetic nervous system are wrestling over the SA node, and neither one of them are off completely. So we're going to see a decreased chronotropic response. Rarely do we see heart rates over 120 in persons with T3 injuries and above. And oftentimes, at least initially in the acute stages of spinal cord injury, we can see dysrhythmias, heart block, and a relative bradycardia. Some folks will brady all the way down into the 30s or 20s and require transcutaneous cardiac pacing, for example. So in addition to the lower heart rate under the neural influence of the parasympathetic nervous system, we're going to see a reduction in afterload, that is hypotension. Now, in the acute phase, often people show up in the ER following a trauma, and they will have lacerations, they will have bleeding, and their vascular volume will diminish as they lose blood. And so usually in response to that, so we see a lower blood pressure, we see hypothermia, and we see a compensatory tachycardia as the heart tries to maintain its cardiac output to perfuse tissues. Following spinal cord injury, however, in the acute setting, we see a low blood pressure associated with a withdrawal of the sympathetic nervous system, or blunting of the sympathetic nervous system, even in the face of low blood pressure. And so with less sympathetic influence on the SA node, we're going to see a relative bradycardia. And so this is a situation where you don't have compensatory tachycardia to help out. And so these folks are going to be in trouble early on, and we're going to have to judiciously manage their fluids, which are typically given to overcome the hypovolemic shock. If we over-infuse fluids into the cardiovascular system, we could cause a pulmonary edema. And so recognize that, because your heart simply isn't responding appropriately as you're going through this. So as we get these folks out of the ICU and ultimately into the inpatient rehabilitation facility, one of the first things we're doing in the first week, the most important part, is to be able to help folks sit up without passing out. And so we'll have a recline or tilt in space wheelchair, power wheelchair that they'll be working with. We will provide an abdominal binder to compress the abdominal contents against the inferior vena cava and help squeeze the blood back up. That is, increase the left ventricular end diastolic volume by increasing the preload. We will use elastic stockings, not TED hose. We'll talk about TED hose in a minute. So compression garments to help squeeze blood from the lower extremities up to the inferior vena cava, up to the heart to again increase the left ventricular end diastolic volume. And that said, that still may not be sufficient to keep their blood pressures up because their afterload, total peripheral resistance in the face of this relative parasympathetic dominance now is going to be diminished. And so perfusion, including perfusion to the brain, is going to be decreased in that scenario. So we'll provide salt tablets to try to increase their total vascular volume. And then typically we're not using ephedrine, but we use fludrocortisone or Florinef to try to expand the vascular volume, as well as midodrine chloride to cause vasoconstriction, both in the arterial and venous systems. So these are all mechanisms that we use to try to sustain blood pressure so that the person doesn't become pre-syncopal or syncopal as they're trying to participate in therapies. So the venous stasis that we talked about, especially early on in the course when a person is likely to be in spinal shock, the muscle pump simply isn't working. What does the muscle pump usually do? As the muscle contracts, it forces venous blood upward, and then when the muscle relaxes, the valves close and allow for the blood to stay where it is. The muscles pump again, pushing the blood forward as we're going through. We know after spinal cord injury, though, we've got impaired muscle pump, we've got Veno Dilation, as I talked about, and impaired ventilation. What's that got to do with it? Well, remember, as you take a deep breath, you're creating a vacuum, essentially, and that's also going to help the blood return, the vacuum in the thorax, because it is transmitted to the heart as well. So without, because of the neurogenic restrictive and to some extent the obstructive lung disease, the person is not going to be able to take in a full inspiration. And so that's also going to decrease the blood return to the heart as we're going through there. Now, in the first 4 to 8 weeks after spinal cord injury, we've also demonstrated a change in the clotting cascade components. So we see an increase in factor 8C, which is a procoagulant glycoprotein produced in the liver. And we see a almost twice as much increase in factor 8 antigen, the von Willebrand factor. And remember that that comes from the endothelial cells. So this ratio is changed to increase the collagen-induced platelet aggregation, that is the likelihood of clotting. And that, like I said, occurs within the first 4 to 8 weeks. Usually after 8 weeks, this resolves and goes back to normal clotting physiology as we go through this. And then recognize that typically associated with this, we're going to see vascular injury, to the endothelial wall, either because of trauma or because we just put IVs in there, and that is causing disruption, is causing the injury to the endothelial wall and puts people at risk for these things. So potentially inflammation, infection, and tumor can also cause this essential clotting cascade. And so all of these things put together, the relative venous stasis, the hypercoagulability, and intimal injury puts people at high risk for VTE, venous thromboemboli. So let's talk through what that means. So DVTs, deep venous thrombosis, happen when blood clots right next to those endothelial wall injuries that we had talked about earlier. And the platelet aggregation is going to increase in this environment of hypercoagulability, stasis, and intimal injury. If the person is a smoker, you're going to have an increased risk. If the person is on oral contraceptives, you're going to have an increased risk as well. And then those with cancer, diabetes, and fractures are also at additional risk for VTE. What are the symptoms of a DVT, a deep venous thrombosis? Typically, you or I would experience thigh or calf pain and swelling. A person with spinal cord injury wouldn't necessarily feel the pain because the block of sensory afferents up to the brain. We might still see lower extremity swelling, usually unilateral, but not always. Sometimes it can be bilateral. Relative warmth, rubor and cords, venous cords in the lower extremities, and then a positive Homan sign, remember, which is passive dorsiflexion as you're squeezing the gastroc. So these folks are also at risk for a post-phlebidic syndrome, where you have clotting in the entire lower extremities, all the way up to the iliac and sometimes the inferior vena cava as we're going through there. That in and of itself is problematic. However, the most worrisome component of a DVT is the fact that it can break off. And if it breaks off and travels, then it's going to travel up the inferior vena cava to the right atrium, the right ventricle, and get lodged in the pulmonary artery. Subsequently, you can't pass additional blood through that blockage. And so you're not going to be able to have blood to exchange oxygen and carbon dioxide, and the person will become hypoxic. So we're going to see the symptoms with an acute cough, shortness of breath, and chest pain potentially. Again, in our folks with spinal cord injury, you might not see that. They just may get autonomic dysreflexia. Relative tachycardia, again, it might only go up to 100, 110, as opposed to a person without a spinal cord injury where we might see it get much faster. And tachypnea. So they're already at risk because of neurogenic restrictive lung disease for fast breathing, tachypnea, because of a low tidal volume. You're going to see that amplified in the face of a pulmonary embolus. They will typically have diminished breath sounds and wheezing and potentially a friction rub as you're listening to the lung sounds. Syncope and cyanosis are common, but the person might only have symptoms of anxiety, restlessness, and a mental status change. In some cases, that might be the only clue that you've got a PE. And so all of you on the spinal cord injury service, you're going to have a low index of suspicion anytime your patient has a mental status change. Because the thing that could kill them in that scenario, yes, sepsis eventually, et cetera, but the thing that could kill them immediately would be a PE, a pulmonary embolus. And so you'd have to get that managed quickly. Others in the differential diagnosis include pericarditis, a myocardial infarction, and heart failure, all of which, by the way, remember, an ischemic heart below the level of the spinal cord injury, so particularly in cervical spinal cord injury, those could cause, that's a noxious stimuli below the level of the injury, could cause autonomic dysreflexia. And so then you're caught in this crazy scenario where the person is having autonomic dysreflexia as a result of a PE. And so again, potentially pleuritis and pneumonias could be associated with this. So we, as much as possible, try to prevent DVTs. Certainly, we're going to provide routine thrombo prophylaxis. That may be, ideally, that would be with low molecular weight heparin, and potentially with mechanical devices, pneumatic compression devices, et cetera, as we go through here. So these are the guidelines from CHEST in 2016, soon to be updated. The Paralyzed Veterans of America Consortium for Spinal Cord Injury Medicine put out updated VTE guidelines for spinal cord injury, also in 2016, recommending TED hose plus minus. Now, what does TED stand for? It's not a TED talk. It's thromboembolic deterrent, okay? And these are the white hose that everybody seems to wear as they come onto the rehab floor. And let me just say, it's a wonderful marketing scheme, but TED hose have not been demonstrated to prevent thromboembolism. And so they're not really a thromboembolic deterrent. However, they do prevent skin shear and tearing. And so if I'm going to use pneumatic compression devices, I always want to put them over a TED hose to keep the skin intact. Now, an inferior vena caval filter. Remember, you put this there, it's like an umbrella to catch traveling clots and keep them from going to the pulmonary artery. That is not recommended as a primary prophylaxis. So back in the 90s, in the early 2000s, the trauma surgeons were using and putting these inferior vena caval filters in almost reflexively. Now we've convinced them that this is not the best way to manage this. If at all possible, we want to use prophylaxis that is chemical. So low molecular weight heparin would be ideal. The direct oral anticoagulants can be considered during the acute spinal cord injury. We don't recommend adjusted dose unfractionated heparin unless low molecular weight heparin is not available, which would, I guess, potentially happen, but I haven't seen that in many years. Or if the person has a bleeding risk, then that's reason to not move forward with the chemoprophylaxis and considering instead using mechanical prophylaxis until such time as you can begin low molecular weight heparin. And that's usually a discussion with the trauma surgeons and the neurosurgeons moving forward. So how long do you continue this? Uncomplicated, incomplete, and complete spinal cord injury, we recommend 2 months, 8 weeks. For those with additional risks, so as I talked about, the smokers, the folks who had been on oral contraceptives, those types of things, certainly cancer, we're going to continue a little bit longer. Why 8 weeks? Again, because usually that's when the clotting factors kind of resolve. So you have 1/3 of the equation diminished. The other thing is that we are typically using more and more of mechanical means to help overcome the venous stasis that occurs. And so those two things typically are going to be changed when the person is in acute rehab. Hopefully also we're able to get the IV catheters out, and so the risk for endothelial vascular damage is going to be diminished as well. Sequential or pneumatic compression devices. Again, there's no literature to support independent efficacy of TED hose, but we use this to keep the skin intact as we're using pneumatic compression devices, especially during the first 2 weeks, whether the person is on chemoprophylaxis or not. So part of this is blood expulsion from the lower extremity. However, the major reason why sequential compression or pneumatic compression devices reduce a person's risk for VTE is because it increases antithrombin 3 released from the vascular endothelium. And so that is going to put the person at less risk of having a VTE moving forward. When we are moving a person from the acute medical setting or surgical setting to the IRF, so the acute rehab center, we don't recommend a routine lower extremity Doppler ultrasound. In fact, some of our residents a few years ago did a quality improvement project looking at that and demonstrated we could save significant costs if we didn't do this, unless there was reason to believe that the person has a new VTE or DVT. The inferior vena caval filter I've talked about a little bit. Indications are when chemoprophylaxis is contraindicated because of bleeding risk. However, we do recommend if the person has had recurrent PEs, despite anticoagulation, then it's appropriate to put this filter in. Remember, the filter goes in through a femoral vein, goes and is opened up like an umbrella, and it sits in the inferior vena cava, Ideally, it's placed up above the level of the renal artery so that there wouldn't be dislodgement if a person had to use mechanical quad coughing, is what we used to call it. So we would recommend this for folks who have PE with hemodynamic compromise, compromised cardiopulmonary function. But again, this is not recommended as primary prophylaxis as we move forward. Recognizing these complications, filter migration, again, associated with quad coughing. Again, if the inferior vena cava filter is placed high enough, then even quad coughing doesn't cause dislodgement, as demonstrated by Lazar Greenfield's group out of Michigan, who invented the filter and has been monitoring its success over several decades now. So let's move forward and talk a little bit about chemoprophylaxis. Low molecular weight heparin, enoxaparin, dalteparin are recommended and are superior to using unfractionated heparin. So typically 30 milligrams sub-Q twice a day, or David Chen's group had reported out, I think, again, this was in the 90s, that 40 milligrams once a day would be sufficient for most folks with spinal cord injury. However, there's a little bit of a mixed discussion on that. And so usually what I recommend for folks with spinal cord injury is 30 BID. We'll maybe see some additional literature coming through on that in years to come. If a person has developed heparin-induced thrombocytopenia, then you might have to move to these other low molecular weight heparins that are much more expensive, but don't cause or don't contribute to the heparin-induced thrombocytopenia that, in fact, these two can contribute to. So again, unfractionated heparin, if low molecular weight heparin is not available, is our alternative. So for incomplete spinal cord injury, 5,000 units twice a day. For a complete spinal cord injury, it's recommended that you do dose adjusted 3,500 units Q8 to find an APTT that is 1.5 to 2 times normal. Back in the day, we had to do that all the time. Nowadays, it's rare that we can't use or can't have available low molecular weight heparin, and so fewer and fewer of our patients are actually on unfractionated heparin. Warfarin is not indicated as primary prophylaxis. So if you suspect a DVT because of the symptoms that we talked about earlier, the typical workup, basically we're going to jump right to Doppler ultrasound. These days it's relatively quick. We can get these done fairly quickly. We worry very much about a pulmonary embolus. So a DVT that breaks off, so a venothromboembolus basically can get lodged, again, as we talked about, in the pulmonary artery. If you suspect that, then you can check a blood gas. Your PaO2 typically is going to be less than 80, and we want to move immediately to spiral CT. Back in the day, we used to use VQ scans really to demonstrate the mismatch between the blood flowing and the oxygenation. We've realized that that is, while highly sensitive, not very specific. And so the spiral CT is so much more available now. We jump to that as our first step if we think somebody has a PE, potentially after getting a blood gas as you're moving forward. So if you find somebody with a DVT or PE, how do you manage them? If they're cancer-free, then consider using direct oral anticoagulants. So again, these particularly apixaban is the one that we're seeing most frequently in our center. And I would prefer those over the vitamin K antagonists, and those are preferred over low molecular weight heparin. On the other hand, if you have a cancer associated with your spinal cord injury, then you're going to stick with the low molecular weight heparin as the first choice. That's going to be better than the vitamin K antagonists and better than the direct oral anticoagulants. So the treatment period for the first DVT or PE is 3 to 6 months. If a person, you take them off after 3 to 6 months and they develop a new DVT or PE, then you're going to continue essentially for a lifetime. Oftentimes then we'll be sticking with apixaban, for example. As necessary, again, recurrent PEs, you might want to consider an inferior vena caval filter. Recognize that around 2010, they started making these filters so that they could in fact be removed. And so that's a possibility now that wasn't available to us a couple of decades ago. So if we're not going to be looking at the direct oral anticoagulants, then low molecular weight heparin is going to be used. We shouldn't use a single daily dose exceeding 180 milligrams, but we are going to provide essentially 1 mg per kg every 12 hours, or 1.5 mgs per kg per day subcutaneously. I am more conservative, and so typically we'll use the 1 mg per kilo every 12 hours. Starting warfarin therapy on day 1 at 5 milligrams and then adjusting as subsequent daily doses according to how the INR is improving. Check the platelet count somewhere between days 3 and 5. Assuming that you get to your INR between 2 and 3, you can stop the low molecular weight heparin after an additional 4 to 5 days once you've had the combined going. And then anticoagulate with warfarin Coumadin for at least 3 months in an INR range of about 2.5. That is between 2 and 3. Now I'm going to change gears, unless there are questions. And you guys have been so rowdy that it's hard to believe that you don't have any questions. But I'm going to go ahead and move forwards and talk about heart disease in spinal cord injury. It is still the leading cause of mortality in chronic spinal cord injury. In acute injury, we worry more about pulmonary and pneumonia and sepsis. But in chronic, it is heart disease that we worry about, particularly with those folks with higher levels of injury having silent ischemia. Not just because of diabetes, which they're at high risk for, but because they lack the afferent innervation to tell them that they are having cardiac ischemia. Risk factors for all of us include cigarette smoking, hypertension, family history, and a male gender. But for our folks with spinal cord injury, they're particularly at risk because of a relatively imposed sedentary lifestyle, insulin resistance, obesity, and dyslipidemia associated with their spinal cord injury. Remember how atherosclerosis occurs. You get injury to the arterial wall, exposing underlying connective tissue. Then you have the aggregation of platelets and monocytes to try to heal the wound, if you will. Platelets, as they collect in the area, release platelet-derived growth factor. That promotes smooth muscle proliferation, and you end up increasing the size of this endothelial wall on one side or around, so that ultimately your lumen becomes more narrow, and it's more likely to catch a small clot that would have otherwise just gone through and broken up and not been a problem. And so you end up with this kind of a scenario where lipids are deposited into this plaque, becomes calcified, and you have a narrowed arterial lumen. Typically, we think about this in the coronary vessels, but recognizing that it's happening throughout the vascular tree and also contributes to our risk for cerebral vascular accidents because of narrowed lumen in the carotids and or the peripheral vasculature. So why do we have this problem with obesity? A lot of it has to do with the energy expenditure reductions after spinal cord injury. When you've lost voluntary muscle contraction, when you've lost bone mass. Both of those are metabolically active tissues. We're going to see our resting metabolic rate dropping by, as much as 50%. And to offset that, the person would have to reduce their intake by 50% with regard to just their resting metabolism. Recognize as well, they're not going to be able to burn as many calories if they're just using their upper extremities because it's a smaller muscle mass. So we'll get back to that in a few minutes. But the bottom line is we develop this hyperinsulinemia. We have impaired lipolysis, and we're going to talk through those a little bit more. And then we have reduced anabolism. And so testosterone levels drop in men, growth hormone levels drop, and we have a relative increase in the corticosteroids. So that most of our folks will develop a positive energy balance, which is not a positive thing. And so within the first year, if you've only got a 200 calorie excess per day, over the course of a year, the person will gain 21 pounds of fat in a year. Now, we probably, if we were just looking at body weight, we wouldn't recognize that because they are losing muscle and bone mass, which are actually much more dense than fat deposition. And so the bottom line is their bottom line is going to increase significantly. And if we look at percent body fat in persons with spinal cord injury with different methods of assessment, we see in general that a BMI, and that's typically used in most other populations to indicate obesity, a BMI of 25 is equivalent to about 35% body fat in persons with spinal cord injury. BMI of 25 is, for you or I, considered normal and or desirable. But in our folks with spinal cord injury, it already reflects significant obesity. And in fact, their body fat is approximately twice that of able-bodied individuals. Again, because of a decreased fat-free mass, muscles, bones, and organs, their bone mineral content is going to drop and their total body water also drops. In response to this increased adipose load, we see an increase in pro-inflammatory cytokines, so high sensitivity C-reactive protein. On average is about 8. It should be less than 2 for all of us. And we see an elevated plasminogen activator inhibitor. That's pi, and significant elevation, more than 4 times normal. So what? Who cares? I care, and you care. You might just not know it yet. Adipocytes. So as you gain fat, those adipocytes impair fibrinolysis. What is fibrinolysis? The ability to break down clots. And so the DVTs, the PEs, part of it, but as well in the arterial system, these clots can cause coronary infarction of the myocardium, et cetera. So usually fibrinolysis is occurring, but adipocytes secrete thrombin activatable fibrinolysis inhibitor and plasminogen activator inhibitor, TAFI and PI, and I think of both of these as sticky substances, and in fact they cause an increase in thromboemboli because they impair fibrinolysis. So our folks are automatically at risk as they accumulate adipose tissue, at risk for thromboemboli. And that's both in the arterial as well as the venous system. We know, in fact, these adipocytes are pro-inflammatory. They secrete a number of pro-inflammatory cytokines, more than I have listed on this slide, but including interleukin-1, interleukin-6, and tumor necrosis factor alpha. In the liver, these are converted to high sensitivity C-reactive protein. And so that's another thing that we're going to see elevated. We know that C-reactive protein increases nuclear factor kappa B, which causes all kinds of problems with regards to the insulin sensitivity, with regard to dyslipidemias, and blood pressures. We know that nitric oxide is diminished as we increase C-reactive protein. Remember, nitric oxide is a vasodilator, and so if you have less of that available, you're going to be relatively vasoconstricted, and you have increased leukocyte adhesions and endothelial cell death. So there are at least 4 mechanisms by which adipocytes cause hypertension. They secrete angiotensinogen, which is the precursor to angiotensin II, which is potent vasoconstriction. So we also, as we talked about, see that adipocytes secrete IL-6, C-reactive protein increases, nitric oxide decreases, so you have less vasodilation, that is more vasoconstriction. Adrenal compression changes the renin-angiotensin-aldosterone system axis, so that basically you increase plasma volume and then you have atherogenesis. And as that occurs, as we had talked about previously, you're going to have a stiffening of the arterioles so that your blood pressure is going to go up. So despite the fact that I said early on, we see neurogenic hypotension, with the accumulation of adipose tissue, we see basically hypertension occurring when physiologically you wouldn't have expected it, except for this huge adipose load. And we reported this first in 2007 and frankly had a difficult time getting the manuscript published because the reviewers couldn't believe that our folks actually had hypertension. Now folks are recognizing more and more that there is this conversion from neurogenic hypotension to a relative normal blood pressure to subsequently hypertension as adipocytes accumulate. We also know that visceral fat causes dyslipidemia. Remember that visceral fat releases these non-esterified fatty acids. Those accumulate in the portal circulation, and subsequently the liver becomes overwhelmed. The bad cholesterol, remember, is going to increase, and HDL cholesterol, the good cholesterol that's there trying to clean up the vascular tree, is going to decrease as these non-esterified fatty acids accumulate. And so subsequently you're left with this scenario with fewer and fewer of the HDL cholesterols to clean up the vascular tree. And so again, an increase in atherosclerosis. We in fact do see a dyslipidemia after spinal cord injury. Baumann and Spungen reported out in 2007, and we reported out more recently. About 2/3 of folks, at least men, with spinal cord injury will have HDL cholesterol less than 40 mg/%, which is kind of your threshold for putting you at increased risk for coronary artery disease. 44% of those reported out by Baumann and Spungen had HDL cholesterol less than 35 mg/%, and 20% had HDL cholesterol less than 30 mg/%. So they just don't have the garbage truck fleet to clean up the vascular tree anymore as you accumulate more and more adipose tissue. And then adipocytes cause insulin resistance. Part of this is due to the PI3 kinase cascade, where you have an accumulation of fatty acyl-CoA, diacylglycerides, and ceramides within the cells. Actually, there are 9 different mechanisms by which adipose tissue causes insulin resistance, and I'm not going to take this time to go through those. I will talk about those in our next lecture. We know that there is a higher cardiometabolic risk after spinal cord injury because of obesity and the likelihood they will develop prediabetes, hypertension, and dyslipidemia. Nutrition and physical activity are going to be our highest recommendations. Pharmacotherapy, certainly, to try to reduce or change the dyslipidemia, and as necessary, the blood pressure changes. So I'm running out of time. We're going to spend more time talking about diagnosis of coronary artery disease after spinal cord injury. Recognize that our folks, particularly with higher levels of injury, are going to have a silent ischemia, and yet a lot of times we wouldn't be able to demonstrate this with a usual graded exercise test. So for spinal cord injury, we do recommend a dobutamine echocardiogram. This would be our gold standard moving forward. Exercise screening is still going to be helpful if we're going to be trying to prescribe exercise intensity and duration as we go through, recognizing that most of our folks with spinal cord injury are going to have an altered blood pressure, altered lipid profile, and insulin sensitivity. They are going to be obese and be relatively impaired in terms of their activity levels. They will also typically, unrelated to their potential coronary artery disease, have shortness of breath on exertion, dizziness and syncope related to circulatory hypokinesis, ankle edema because of gravity dependent influences on the lower extremity, and what you and I would call an unusual fatigue or shortness of breath with usual activities. So the bottom line is I recommend testing these folks, particularly if I'm going to prescribe exercise, and having a physician present during the assessment just in case. We recognize risk factor modifications are we can't usually change age, family history, or gender. However, cigarette smoking, hypertension, lipids, and diabetes are things that we can change, and certainly exercise. Cigarette smoking, for a number of reasons, is going to make their risk for heart disease significantly greater. And so trying to get them on a smoking cessation program as soon as possible. Managing their hypertension with pharmacology is appropriate, but diet and exercise. Lipid profiles, basically we're going to try to modify their diets, but recognize it may also be necessary to use pharmacological agents, including the statins and niaspan. And we do have recommendations in terms of managing their type 2 diabetes for those who have demonstrated that, considering starting with metformin and then moving forward according to the ADA recommendations. We're going to talk through over the next couple of weeks the best way to manage obesity, the best way to prescribe exercise and diet for this folks, recognizing that ideally we're going to be looking at their energy expenditure using indirect calorimetry. We're going to predict their energy expenditure on a daily basis and use that as a way to prescribe an appropriate diet. We've got some ongoing research, believe it or not, it actually has been approved to move forward now, called Science. So spinal cord injury, exercise, nutrition, conceptual engagement has been on hold because of the pandemic. We've got permission to move forward with this protocol now, in which we are going to be using interventions, either a diet alone or diet and functional electrical stimulation, leg cycle ergometry, to see if we can improve body fat, fat-free mass, and insulin sensitivity in our folks with spinal cord injury. For those with incomplete injuries who are ambulatory, they are also at risk for peripheral vascular disease, and particularly peripheral arterial disease. And the management is as it would be for able-bodied individuals, essentially trying to improve exercise and modifying their risks as we move forward. And then finally, and we'll get back to this, why are we all aging? Which, by the way, is better than the alternative. But we age, and as we age, we see an increase in inflammation associated with adiposity. We see this formation of free radicals, partly because of the adiposity, and then hypoxic conditions. And in spinal cord injury, this is also because of neurogenic restrictive and obstructive lung disease. So ultimately, our folks with spinal cord injury are at increased risk for aging, an accelerated aging process. And we have seen that in some very well-known figures with spinal cord injury over the years. So I've used up just about all of my time, although I do have a few minutes left for this very robust and rowdy crowd. Feel free to, again, voice your questions, thoughts, and concerns. I'd love to engage you in discussion, even more than we already have. This is me giving permission to the residents and fellows to jump in here. Woe is me. And again, our residents and fellows may have fallen asleep. I've got to find a way to keep you more engaged as we go through these presentations. So next time through, things will be a little different. Nonetheless, thank you for those of you still awake. And hopefully this will give you food for thought moving forward, but not too much. So everybody have a great day and a great week. I'll be back next week to talk about obesity and metabolic syndrome after spinal cord injury.